My name is Jamie Irizarry, and I am a nursing informaticist at the Children's Hospital of Philadelphia. The title of my presentation is Medication Safety Technology, Administration, and Monitoring. Here is the financial relationship disclosure for this activity. These are the learning objectives that will be covered in this presentation.
The next two slides include key abbreviations for your reference throughout this presentation. Your self-assessment question for this module is, which safety technology is not a part of the administration phase? A, electronic medication administration record. B, barcode medication administration. C, naloxone trigger tool. D, smart infusion pumps. We will review the answer to this question at the end of the module. We're going to begin this module talking about the administration phase of the medication process. As EHRs become the standard of care in acute settings, CPOE and EMRs have taken the place of handwritten orders and medication administration records. Much of the administration phase relies on the information that is held in the EMR, which serves as the source of truth for the clinicians administering the actual medication. This is an example of an EMR for a continuous infusion of milrinone. Note that the 5 rights of medication administration, patient, medication, dose, route, and time, are all clearly displayed. When designing an EMR, the clinicians and informatics team should consider the font size and use of bolder italics to highlight critical information. Teams should also consider the order of information in the EMR and how it corresponds to hospital-generated medication labels, as well as the order that information is programmed into infusion pumps. In addition to the basic rights of medication administration, the EMR can provide a plethora of information that is stored in the electronic health record. The EMR has the ability to show where a medication is in the verification and dispense process, including the actual dispense location, such as pharmacy or an ADC. It can provide administration instructions for the clinician or use hyperlinks to connect hospital formularies, procedures, and job aids. An EMR can also be set up to include additional safety checks, such as dual signatures for high alert medications and the date and time of recent administrations. The transition from paper medication administration records to EMRs has had a wide impact on medication safety. Similar to CPOE, the EMR has eliminated many of the issues with transcription and legibility. Since the EMR is part of the EHR, it is easier to access patient information, such as lab values, patient allergies, and most recent weights. Hospitals can require certain aspects of the medication order to be required so that prescriptions are complete, and the use of order sets can provide guidelines and clinical decision support to ordering prescribers. There are also features that allow orders to be linked. For example, whenever a paralytic is ordered in the ICU, an order for eye lubricant ointment can be automatically populated. Or another order can be set to begin when a specific order completes. For example, with steroid weans or antibiotic desensitizations, where you wouldn't want the second order to begin until the first order was completed. Alerting can also be enabled within the EMR to notify the administering clinician about things like drug-drug interactions, early and overdue administrations, as well as when they have reached a 24-hour max dose for medications that may have limits. The use of EMRs has also allowed for the development of new medication administration technology, including barcode medication administration and the integration of infusion pumps with the electronic health record, both of which we'll talk about later in this module. There are challenges and limitations associated with the EMR. Moving to an electronic version of the medication record did not improve efficiency and documentation for the clinicians administering medications. Consider this fact when evaluating how much information is presented for each medication. How much information is too much information? Ideally, the EMR would be available for the clinician to view just before, during, and after administration. This may be an option when using a mobile app if available, but oftentimes clinicians have to use computers that are not mobile and may be located across a room or in a hallway. Orders can appear to have dropped off the MAR based on a completed or expired order. This feature can be helpful to reduce clutter in the MAR and inactive medications, but it can also occur in error if the duration was ordered incorrectly and no clinicians picked up on it before it disappears from the MAR. Similar to other technology, when downtime occurs, there are challenges with converting to a paper system, especially with a growing percentage of the workforce who has only ever used electronic MARs. Earlier, I mentioned that it is important for the information displayed in the EMR to support nursing or respiratory therapy workloads. Oftentimes, this information is not presented in the best fashion for the end user. EMRs are commonly built to show the available product on the first line as known to the pharmacy for distribution, with the actual dose not occurring until the second or third line. Ideally, the top line should include the dose first and not the full vial. For example, if the top line reads insulin 100 units per ml, a potential error could occur if the clinician inadvertently administers 100 units. Consider the ability for clinicians to access the EMR when removing medications from an automated dispensing cabinet. This can be a challenge depending on space and location, but the list of medications in the ADC may not be a complete picture of the EMR. Another feature that can present challenges depending on the EMR build related to dosing windows and the ability for nurses to manipulate due times to ensure a dose is accurately documented when it is necessary to adjust the timing to get back on track. For example, when a study occurs and a dose needs to be delayed, how do you then reschedule all future administrations? Adjusting medication due times in the EMR can be a complicated process for either nurses or pharmacists and gets additionally complicated when there are a specific number of doses ordered or when changing the due time also involves a new date. Hospitals should have a system in place for this because it occurs frequently. I would encourage you to review ISMP's guidelines entitled Safe Electronic Communication of Medication Information that discusses electronic system design features for medication information and specifically the safe presentation of drug names. The hyperlink has been included for your reference.
We are now going to talk about some of the more advanced medication safety technology options that using an EMR offers. Barcode Medication Administration, or BCMA, provides an additional layer of safety to the medication administration process. In addition to the clinician performing the 5 rites of medication administration prior to administering a medication to the patient, BCMA should be used to perform a check of the manufacturer NDC or hospital label ID number against active orders in the patient's EMR. The first step in BCMA is to scan the patient's ID band, which opens the correct EMR, verifying the right patient. Next, the medication or IV fluid barcode is scanned, which confirms that there is an active order for that medication. There are some restrictions to what safety checks and alerts BCMA can provide when scanning a manufacturer's NDC. BCMA can only confirm if a wrong drug, concentration, or dose has been selected. In pediatrics, there is an additional restriction on the dose, as it cannot verify partial doses. For medications that have been prepared by pharmacy and use a hospital label, scanning the barcode only confirms that the label matches an active order. It cannot confirm the source container or the volume of the medication. It can, however, alert a clinician if they have picked up the wrong patient's medication. Depending on the EHR vendor, detailed reports are available that show compliance with using BCMA, as well as alerts for wrong patient, wrong medication, and discontinued medication orders. There are also some reports that use logic within the EHR to show medications that may have been administered despite an alert firing.
Compared to other medication safety technologies, BCA is easy to implement. Think about it. We use barcode scanners in the self-checkout lines at grocery stores, and we have scanners in our smartphones. BCMA does not replace any safety steps. So similar to EMRs, it does not improve efficiency of the administration process, but it does provide an additional layer of safety. The data and reports can be comprehensive or granular and provide actionable data for improvement and for review with potential medication errors. However, you don't know what you don't know. There's no baseline data that you can look at before BCMA is implemented. So when you're looking at reports and you're finding things that don't make sense, you need to take the time to do a deeper dive and figure out what may have been occurring, because it may have been occurring prior to go live and you just never knew about it. An example here shows 9 different tablet forms. Prior to BCMA, if the wrong form was dispensed by pharmacy or the nurse picked their incorrect dose out of the ADC, it might never be discovered. With BCMA, an alert will fire, notifying the RN that the medication they scanned is not ordered in the EMR. Prior to this technology, you would have never known. Technology used within the pharmacy may require vendor-specific barcodes for the preparation or storage of medications. These barcodes can be distracting and frustrating to clinicians administering medications since they prompt an alert whenever scanned. Examples of technology that may require independent barcodes include drug repackagers, IV robots, medication tracking barcodes. The scanners themselves can cause challenges with variation in sensitivity, ergonomics, wired or wireless, and locations in patient rooms. Certain medications present challenges when using BCMA, especially medications that require preparation by the administering clinician. Examples of this include medications that require reconstitution and dilution, crush and mix, and multi-dose vials. Multi-dose vials, if done in the medication room and not at the bedside, can affect the integrity and availability of the barcode. Some EHRs have developed medication room workflows that allow scanning of the medication barcode in the med room, followed by the patient barcode at the bedside. Use in outpatient and procedural areas, including the emergency department, periop or anesthesia areas, radiology, ambulatory infusion centers, may require modified workflows due to the nature of those locations. Workarounds can occur with all types of medication safety technology. They occur more frequently when there are problems with either the technology or the environment. One way to avoid workarounds is to engage human factors engineers in the process, as well as to do direct workflow observations in multiple units across the hospital. We're now going to transition from medication safety technology in the EHR to smart infusion pumps. IV infusions started out as gravity infusions that required the nurse to do a manual calculation in order to calculate the flow rate. Next came the earliest versions of infusion pumps, which included programmable rates and volumes, but had safety concerns related to free flow and a lack of safety technology. More recently, smart pumps, as they're called, allow individual institutions to customize drug libraries to meet the needs of their patient population. Dose error reduction software, or DERS, includes options for both soft limits, which can often be bypassed by a clinician, and hard limits, which require reprogramming to doses, rates, weights, etc. Smart pumps also allow customizable clinical advisories. The newest smart pumps also have wireless capabilities, which allow them to receive wireless drug library updates, software updates, and integrate with the electronic health record. Even with DERS, there's a lot of opportunities for programming errors. Each programming step is an opportunity for error. Here's an example of the programming steps required for a smart infusion pump. Depending on the complexity of the hospital's library build and the specific medication, there's somewhere between 9 and 21 programming steps. It is important to note that smart pumps are only as smart as the people who create the library. A multidisciplinary team should be brought together, including nurses, pharmacists, and physicians, to either review a previous drug library or when creating a new one. Hospitals should develop experts in the pump. They should read the pump IFUs, which are the instructions for use from front to back, highlighting any areas that may not make sense with the clinical workflows of the hospital. They should also benchmark with similar hospitals to understand how their drug library is built and challenges that they have had in the past. Smart pump libraries should be consistent with EHR nomenclature, use things like tall man lettering, and have similar alerting structure. There should be clinical simulations and testing of all changes to any drug library by 2 clinicians prior to pushing out a new library. Hospitals should establish an ongoing maintenance and optimization plan for their drug library. There should be multiple checks and balances in place before a library is pushed to prevent errors within the library. As I discussed previously, the use of smart pumps allows individual institutions to customize drug libraries to meet their patient population. There is a place for standardization of certain components of the drug library. ISMP, AAMI, and ASHP each provide guidance for standardized drug libraries. They also provide recommendations for safety features like limiting the number of available concentrations. You can sometimes limit access to medications by patient type or location by creating specific care areas or profiles within the drug library. Each year, ECRI publishes their top 10 healthcare technology hazards. In 2019, number 6 on the list was, confusing dose rate with flow rate can lead to infusion pump medication errors. Factors that contribute to these type of errors include a lack of policies and procedures to lay out the process for verification of pump programming, design issues with the infusion pump programming screens, and variation in how hospitals display information in the EMR compared to how it needs to be programmed in the pump. We spoke about that a little bit before when discussing the EMR. To mitigate these risks, ECRI recommends matching the sequence of MAR information with the pump, standardizing dual clinician pump programming for high-risk medications. They also suggest pump integration with the EMR as the surest way to avoid these errors.
In 2022, ECRI added 2 new smart infusion pump related health technology hazards. Number 3 on their list was damaged infusion pumps can cause medication errors. Identifying damaged pumps is not always easy, as some damage may not be visually obvious to the clinician or may not generate a pump alarm when in use. Damage can occur from a number of reasons, including normal wear and tear, mishandling of the device, or the use of improper cleaning agents or methods. Depending on the type of damage, a pump may run at an incorrect rate, causing over or under infusion of a drug, as well as the possibility of total pump failure, which presents additional safety concerns when infusing critical medications. To mitigate these risks, ECRI recommends that clinicians and any staff involved in the cleaning process evaluate pumps for damage and know how to respond if damage is suspected or observed. A second infusion pump-related technology hazard was included on the 2022 list that especially impacts pediatric and neonatal patients. Number 6 on the list is failure to adhere to syringe pump best practices can lead to dangerous medication delivery errors. Syringe pumps are often used in critically ill children to administer continuous medication infusions at rates less than 5 mL an hour. When infusing at a rate that low, depending on how the tubing or administration set is primed, the dead space of the tubing, the size of the syringe, and the flow rate, a delay can occur between the time that the infusion is started and when the medication reaches the patient. The lack of understanding around lag time can cause initial underinfusion, or if the medication is being titrated based on a clinical response, unnecessary dose increases may cause an overinfusion. To mitigate these risks, ECRI recommends offering standardized drug concentrations that allow for reasonable flow rates for all ages from neonates through adults, and priming tubing using the pump's priming feature instead of manually priming in order to reduce lag time in low flow infusions. Number 8 on ISMP Targeted Medication Safety Best Practices for Hospitals 2022 is focused on the use of dose error reduction technology to prevent medication infusion errors. Dose error reduction technology is usually known as the drug library to clinicians. This is the vendor-specific pump software that allows hospitals to create dosing and rate limits, as well as other clinical advisories for specific medications. To mitigate these risks, ISMP recommends, number 1, administering medications on infusion pumps that have drug libraries with dose error reduction software. It is also important to maintain, update, and test drug libraries on a regular basis. Number 2 is to monitor drug library compliance on a monthly basis and set a goal of 95% or higher compliance. If compliance is significantly lower than 95%, evaluate current practice and medications available in the electronic health record against the drug library. Keeping drug name, dosing units, rates, and clinical alerts consistent between the drug library and the electronic health record can be vital in improving compliance. ISMP also recommends the implementation of bidirectional pump integration with the electronic health record for hospitals that have not already done so. This topic will be covered in more detail later in this presentation.
Smart infusion pumps have multiple challenges. With some pump vendors, clinicians can easily program medications outside of the dose error reduction software with no safety alerts to protect the patient. They can also select the wrong medication or concentration even when using the DERS software. There's a fine balance that organizations need to find when choosing alert thresholds, where they protect most patients but don't over-alert for other patient populations. Infusion pumps don't protect against wrong patient, wrong drug, or wrong line errors. There's also an inability to alert for dosing error that is within the acceptable range. So some patients may be opioid naive, other patients may be opioid tolerant. How do you choose dosing alert thresholds that work for both patients? Certain populations and medications add to the complexity of administration and must have their libraries built specific to these populations. Examples of these include oncology patients, infusion centers, mixed populations, pediatrics, adults, labor and delivery units. There are other significant challenges as well. These include things like a lack of dedicated infusion devices for different routes. For example, some hospitals may use syringe pumps for breast milk as well as for IV medications. Other places may use the same pump for IVs as well as epidurals. It can also be a challenge if hospitals don't have dedicated oversight of infusion pumps to drive updates, agree on changes, ensure upgrades, and ensure that upgrades are installed. We're now going to talk about bidirectional pump integration. Pump integration, or pump interoperability, refers to the process of transferring data between infusion pumps and the EHR. Pump integration with the electronic health record is a vital future step in decreasing the occurrence of medication safety events during the medication administration phase. This technology, if implemented correctly, can eliminate the majority of infusion pump programming errors while also increasing the efficiency of the workflow. Bidirectional pump integration also allows automatic transfer of infusion and intake data back to the EHR, improving the accuracy of documentation. Planning for pump integration is a unique process that requires close collaboration between ordering clinicians, nurses, biomedical engineers, pharmacy, and the hospital information technology team. Here are some questions that hospitals should answer and consider as they begin a journey toward pump integration. Which type of pumps are used at our hospital? Are they all capable of integrating with the EHR? If they're from multiple vendors, how does that impact a possible integration? Does our EHR support pump integration? Does it support pump integration with the vendors that we have? And are we on the correct version of the EHR? Is our wireless infrastructure capable of supporting pump integration? How many devices would need to be on the wireless network? And is it in all locations that patients would travel? Do we have executive support for this safety initiative? And perhaps most importantly, are the multidisciplinary teams willing and able to dedicate resources? Because the EHR will be programming the smart pump, the EHR and pump library must be completely aligned. In order to do this, the formulary and orders for all medications that are given on the infusion pump must be reviewed and updated. There's a lot of pre-work and testing that is required to align these systems. The formulary should be evaluated for any infusions that are administered per day, which is more common in the neonatal and pediatric populations, as well as intermittent infusions that may have suggested administration ranges either in the formulary or in the EHR, such as administer over 15 to 60 minutes. Per day dosing should be eliminated and guidelines put into place for per dose recommendations. Administration ranges should have a default time selected. The EHR will need to be evaluated to review medication orders that can be programmed in the infusion pump and the units that can be ordered. This needs to be consistent between the EHR and the pump. Dose alerting should match the drug library so that the EHR and the drug library have the same alert thresholds. In a large university teaching hospital that has both adults and pediatric patients, consider the drug methylprednisolone. This medication can be ordered as a total dose in milligrams, a weight-based dose in milligrams per kilo, or a BSA dose in milligrams per meter squared. You'll have to establish soft and hard min and max alerts for each dosing scenario, and they will all be needed to be added to the drug library. It's also vital that observations of clinical practice in all nursing areas that will go live are done. This includes medical and surgical units, ICUs, procedural locations, outpatient infusion centers, and any other specific areas you may have. Here are the basic steps for bidirectional pump integration. The first step starts at the top with a medication order that is entered into the EHR. After the order is entered in the EHR, pharmacy must verify the order before anything else can be done. The nurse scans the patient, similar to BCMA. They scan the medication, also similar to BCMA. And the first new step is that the RN scans the infusion pump. This then triggers the electronic health record to send required information from the EHR to the infusion pump. Once the pump receives the data, it is presented for the nurse. The nurse confirms the information and then presses start on the pump to administer the medication. Once the start button is pressed, the information is sent back to the EHR that the pump is now infusing, and the nurse can then complete their MAR documentation. And this cycle then continues to any modifications or new orders that may occur. The first part of pump integration, or bidirectional pump integration, is auto programming. This is the part where the EHR sends information from the order to the infusion pump. The following information is sent to the pump: a patient identifier, it could be a count or medical record number, a patient weight or BSA if you're doing some sort of weight-based dosing, the medication name, some sort of unique medication identifier. This is something that has been pre-established between the pump and the EHR for each medication. This allows multiple medications to map to one entry in the pump, such as IV fluids. A dose and/or a rate is sent, as well as the medication concentration and volume to be infused. A duration is sent if applicable as well. The second part of the bidirectional pump integration is auto documentation and auto verification. This is when information from the pump flows back to the EHR. This includes the volume that is infused since the last time documentation was completed, any changes in the rate, duration, or dose, any infusion starts, pauses, restarts, or stops. And it also performs a check between what is ordered in the EHR and what is actually programmed and running on the infusion pump. Even with dose error reduction software, there are lots of opportunities for programming errors. You can see here that pump integration helps remove many of those programming errors, the steps that have a line through them. New steps have an asterisk. We discussed earlier that programming an infusion pump without integration requires approximately 9 to 21 manual programming steps. You can see, using pump integration, it reduces 7 or more of the most critical programming steps, which are then done by the electronic health record, reducing the risk to patients of human error. Pump integration with the EHR has major impacts to medication safety, especially with some of the most critical medications that are administered to patients. Because the EHR programs the infusion pump, you reduce or eliminate the potential for manual pump programming errors. There's accurate EMAR documentation with medication administration times and durations, since they're pulled directly from the pump. There's also standardized nursing workflows for IV medication administration, because pump integration doesn't have much tolerance for individual workflows. There's also actionable data that will be developed from pump integration and the EHR. Oftentimes, vendors from both the EHR and the pump vendor will provide data that can be put together to figure out a complete picture of what's been programmed and how your hospital is using pump integration. Most hospitals and pharmacies make frequent changes to the EHR, including the addition or removal of medications, changes to dosing guidelines and updates, or the creation of order sets. All of those changes will need to be aligned with the pump, and if there are impacts, they need to go live simultaneously. Pump integration has a lot of downstream impacts throughout the EHR that should be evaluated, including impacts to flow sheet rows and reports. Alert fatigue is a very real problem with pump integration, as clinicians can receive similar alerts from both the pump and the EHR, and they could be repeated as much as hourly, depending on the type of alert. The room layout should be taken into consideration, as the clinician will have to have easy access to the infusion pumps and the EHR when scanning. Unlike BCMA, which has almost no resistance to implementation because people are used to using it in their day-to-day lives, bidirectional pump integration is still a new technology that may take time for clinicians to buy into. Reducing alert burden and improving efficiency in workflows can help ease the transition. There have also been discussion about security concerns due to the wireless nature of patient information flowing between the EHR and the pump. This is something that you should address with your pump vendors prior to go live. We're now going to discuss medication safety technology that is available for the monitoring phase of the medication process. Active patient monitoring technology includes physiologic monitoring and point-of-care testing. Physiologic monitoring that is applied during and after medication administration should be considered just as important as other technologies we have discussed throughout this module. It is not technology that might prevent medication errors like an IV robot, or catch medication errors prior to administration like BCMA, but appropriate physiologic monitoring can mitigate the harm, which is a primary goal of using medication safety strategies. Over the years, there have been numerous reports where the lack of appropriate monitoring after the use of opioids, PCA, or sedation has resulted in serious outcomes and even death due to either failure to recognize or failure to rescue. The ability to have monitoring technologies available when certain medications are administered is an important consideration when deciding in which locations certain drugs should be safely given. Point-of-care testing, such as bedside glucometers and urine dipsticks, should also be considered active patient monitoring in this phase of medication administration.
Active surveillance includes real-time monitoring of patients. An example of this is the Vaccine Adverse Event Reporting System that is run by the CDC and the FDA in order to track unusual or unexpected patterns of adverse events related to vaccines that could possibly pose a safety problem. Another example of active surveillance is MedWatch, which is the FDA's medical product safety reporting program for health professionals, patients, and consumers. This reporting system is similar to the vaccine reporting system, but instead is for reporting of adverse events related to prescription and over-the-counter medicines and biologics, including blood components and derivatives. The FDA Adverse Event Reporting System takes reports submitted by healthcare professionals and patients via MedWatch, as well as required reports submitted by drug manufacturers, and makes them available to the public via the FDA Adverse Event Reporting System database. Unlike the other examples of surveillance, MedWatch and VAERS are a passive reporting system, relying on clinicians or patients to report ADRs. The remaining examples of active surveillance rely on complete and accurate documentation in the EHR. As antimicrobial stewardship is integrated with the electronic health record, the clinical decision support tools available have increased the ability of the ASPs to both evaluate antimicrobial use and provide interventions when appropriate. It also enhances the data available to track key metrics. Clinical pharmacy work prioritization tools and pharmacy acuity scoring tools take information from the EHR and assign scores or rankings to guide clinical pharmacists in prioritization of work responsibilities.
This is an example of a pharmacy acuity scoring tool. The clinical pharmacy team created a predetermined scoring system that helped to prioritize patients with higher acuity to be reviewed first. The scoring also allows for improved communication between team members as well as at handoffs of care. As with many other technologies we have discussed, ongoing maintenance and optimization are critical to ongoing success. A more global look at monitoring patients and ADEs involves the use of trigger tools. The Institute for Healthcare Improvement created a tool that pharmacists could use to monitor and measure adverse drug events across an institution. The original toolkit provides triggers or clues that reviewers could use in a retrospective review of patient records. The trigger tool supported the tracking of 2 measures, including ADE per 1,000 doses and the percent of admissions with an ADE. This type of monitoring is helpful to look at ADEs across a hospital or network, compared with the active surveillance, which is more patient-specific. The IHI trigger tool was an example of a traditional and more paper and pen tool that was developed. As hospitals have transitioned to EHRs, new trigger tools have been created that are based on EHR surveillance. Examples of this are listed below. One such tool involves a report that fires every time naloxone is administered. You can have the EHR filter out locations, such as an emergency department who may administer naloxone due to patient diagnosis, and add other layers, such as patients who received an opioid in the 24 hours prior to the naloxone, to filter on your report. This methodology can also be used for laboratory values, such as drug levels, glucose, and serum creatinine. The medication safety technologies used in the monitoring phase have really progressed since we've transitioned to electronic health records. They provide more comprehensive patient lists based on predefined criteria. They allow real-time information to be provided to practitioners, They increase efficiency and expand coverage of patients that may be integrated into this. And they can help you have a global look at adverse events across a hospital and/or a network. We're now going to readdress our self-assessment question. Which safety technology is not a part of the administration phase? A, electronic medication administration record. B, barcode medication administration. C, naloxone trigger tools. D, smart infusion pumps. The answer is C, naloxone trigger tools, as this is an example of medication safety technology in the monitoring phase of the medication process. To review this module, medication safety technology supports the administration phase through the use of EHR, includes the EMR, BCMA, and smart infusion pumps. This technology has recently expanded to include smart pump integration. Smart infusion pumps require an extensive initial library build, ongoing maintenance, as well as oversight and monitoring of usage and alert data in order to optimize patient safety. Vast amounts of data are available related to the EMR and smart pumps, requiring dedicated time and resources to analyze and make appropriate adjustments. Implementation of active surveillance programs such as pharmacy acuity scoring tools and more global surveillance such as trigger tools allow clinicians to monitor the needs of specific patients as well as patient populations. Here are your references for the module. Thank you for your time and participation.